Hopefully everyone can see my screen. Welcome everybody to this evening's webinar. I know it's sort of that dinner time and many of you will have your cameras off, but if you are able to put your cameras on and that would be wonderful in terms of connection, but totally understand if just that's not possible for this evening, because I know many will be multitasking and cooking dinner. So all good. I really appreciate obviously you guys taking the time this evening to join us for this webinar on improving access to primary care, back to basics and benefits of healthcare home model of care. And we have Dr. Andrew Miller, Dr. Kirsty Lennon and Whaea Merle Samuels sharing their wisdom and whakaaro this evening. So no mai, haere mai, welcome. I'll start with opening karakia, he karakia timatanga. Tu taua mai I ranga, tu taua mai I raro, tu taua mai I waho, tu taua mai I roto. Ke to ai, te mauri tu, te mauri ora, ki te katoa, homie, huie, tai kie. I just invite you to write in the chat, and by way of, covering some whanaungatanga, creating connection. But if you want to put in the chat where you're from, and maybe just a little bit about yourself in terms of role, that would be lovely to see who is with us this evening. So again, this is just our coverage tonight, really bringing it back to the core of supporting general practice, improving that access to primary care. I want to take 1 minute to set the scene around Collaborative Aotearoa, and many of us know us, many of you know us well in terms of who we are and the work that we do to support the primary health organisations as our members and others, and work that supports then general practice. So like many others, we have a vision for ensuring that we're working towards equitable futures and that real focus on health and well-being outcomes every day to ensure whānau flourish. Now, many other organisations will have that same vision. I guess what our real focus in terms of mission is through whakawhanaungatanga. We work with organisations to adapt and learn faster than any other, and that fits with that national learning perspective. And we really wanted to articulate our promise to the network in terms of the support, because it's really those that are at the front line and those that are actually doing the mahi is where it really counts. We are really that support service and enabler. We have three main areas currently in terms of healthcare home, which you'll hear about tonight, digital health, but also collective action with communities to enable that place-based planning or localities mahi. Believe that change in relationships changes well-being, and we know, and everything that I've learned on the journey and being having Whaea Merle alongside us, that whakawhanaungatanga is at the heart of our mahi. This is really just setting the context again of our mahi at Collaborative Aotearoa, having worked with our board and others to really put some whakaaro around who we are, what we are. So we really are connective catalysts. I'm not going to read all of the screen, but we are audacious pragmatists. We really focus on that getting the job done, working and responding to those that are, as I say, at the front line, and those organisations that are supporting general practice and other organisations, and then really being focused in terms of the courageous allies walking alongside, again, those that are doing the mahi. So really just wanted to share the context and passion for who we are and what we do. So I'm going to pause there and really introduce our panelists. I probably jumped ahead actually, and introduce myself more formally. So I'll do my peppy hand, and then I'm going to pass over to the panelists to do the same before we get into the detail of our topics. So, ko tararua te monga, ko waikanai te awa, I tipu ake aho I Gateshead, England, ko Whaea Maxwell takutane no wairarapa ai, ko Flinroa, ko Tara aku tamariki, ko Amarjit Maxwell aho, tina koto, tina tato kato. So I'm Amarjit Maxwell. I lead out the mahi at Collaborative Aotearoa, and as I say, most of this audience tonight, many of you know myself and the team, and yeah, just really wanting to, you know, share that connection. I will point out our team members in terms of Patria is here this evening in terms of our new healthcare home change agent, and Jazz is in the background, but she's she's multitasking and she's just recovering from COVID. So I'm not going to ask her to turn her camera on, but she is here with us this evening. But maybe Whaea, if you want to introduce yourself, that would be wonderful. And then we'll hand over to Andrew and Kirsty. So
Tēnā koe Amarjit.
Thank
Tēnā
you.
koutou ana, ko Whaea te mea tuatahi, whapaki ana ngā tai ki mauao. Ko mā tātua te waka, ko te awa nui ārangi me tauranga moana, tēnā te moana. Ko te rere a te kahia te awa. Aroha mai. Ko tama whariua te awa. Ko ngai tama whariua te hapu. Ko mā tātua te waka. Ko Whaea. Ko au te mokopuna o tamāpeke no katikati ahau. This evening I will be sharing about, as one of the team members with using the voice of the lived experience, I am grateful to not only come forth physically, but to bring all those whānau voices that we are able to share that have helped to make this, at the time that I started the model of enhancement, come into being. Nō reira, tēnā koutou, kia ora mai tātou katoa, kia ora Amarjit.
Ngā mihi Whaea. Kirsty, if we go to you, then Andrew can follow and then go straight into his share, and that probably makes sense. So over to you, Kirsty.
Kia ora everyone, I'm Kirsty Lennon. I'm a GP in the Cabin Coast, and I work as a clinical lead for Healthcare Home, both for Tuora but also for the Collaborative. I come from Scotland originally, but I've been in New Zealand now 13 years, and have family with 2 lovely children who are now growing up and being teenagers. I congratulate everyone who's not watching the football tonight. I have been absolutely watching it fervently. We love football in our house, so if you're not watching that and you're here instead, well done. And I'm looking forward to a good night, and kind of reiterating some of the real good focus of the model. So kia ora everyone.
Ngā mihi, Kirsty. Yeah, I was at the game last night with my whānau, and yes, suffice to say it was heart-wrenching, the result, but I've still got a chance Sunday. I'm hopeful. So yes, lots of football fans on here, I'm sure, tonight too. So ngā mihi. Andrew, over to you.
Yeah, kia ora koutou everybody. I'm Andrew Merle. I'm a GP in Te Tai Tokerau, Northland. I've been up here for 28 years. I've been running the healthcare home model of care out of our practice for the last 7. It's pretty actually football crazy in my practice, because Hannah Wilkinson is the daughter of one of our doctors, my partner, Simon Wilkinson. So I played 5-a-side with her when she was a 13-year-old, and she knocked every man over on the field. Phenomenal player. So I'm going to start this webinar tonight. See if I can share my screen all right with you guys. Oops, I'll get to the top of it, not the bottom. That'll help. All right. I hope you can all see that. All right. Does that look okay? Okay. We're talking about a thing. I'm just going to talk about a couple of things which really probably the fundamental platform of trying to get your practice back on track. That's what the little train showing us what can happen, and certainly what was happening at my practice before we got this model of care going, because we weren't really coping with urgent unplanned care and the sheer volume of paperwork, messages and demands from our patients. And what we did using this model, and I think we've ramped it, right up, is get our train back on track. This is a little bit sort of twee, or you've seen it around a bit on the places, but I think it's quite pertinent actually. I mean, the keep calm is, I guess, both for me as a GP, doing this work is keeping the place calm. And dare I say, stay where you are is the reason we set up healthcare homes in Northland, was that we want our GPs to say half our GPs intend to retire in the next 5 years, and they'll certainly retire quicker if they're actually smashed to pieces. So doctor point of view or practice point of view, both those things apply. And that's for patients. If they can access our care and they can do it from the comfort of their own lounge, then both those things are applicable. I think the other thing too is sometimes this is uncomfortable, but if we were to try and explain to our patients what we were doing maybe before we started doing healthcare homes work, and we said that's the services we're giving you, I don't think a lot of it would be reasonable or defensible. If there are other ways of delivering care that actually work and allow them to find ways of having problems solved quickly, easily and efficiently, and we don't offer those things, I don't think that's defensible. We'd probably end up having to apologise. Dare I say, I actually am a patient of a healthcare homes practice in Whangarei who don't offer me secure messaging or open or allow me to actually get hold of them in a way other than actually going in there. Which Triage, I've gone back to them last week to talk about Triage to get them back on track with that, because they weren't doing it. Sometimes I think the reason we have these webinars is sometimes things get in the way and people forget how useful these things are. So I'll talk about that first of all about phone triage, the whys, the hows and the what's in it. I mean, obviously the whys is that this does keep value our patients' time. If they don't have to come in, they don't have to come in. Gives them other options for care. It is actually good for business efficiency. Gives us a massive increased capacity to cope with acute demand, that's for sure. I would question whether at the moment we're actually freeing up proactive and planned care time. I think many of our practices are struggling with workforce and barely afloat. But in theory, if we had more staff, we'd probably be doing that better, because we are freeing up more time. And it gives people choice in how they get to seek their services. So again, other more whys, I guess, that there is a burning platform in terms of our workload. I think it really has increased. Triage is great because it gives you the chance when you're talking to people to actually put them in with the right person in the practice and give them the right length of time, so whatever they need sorting out can be sorted out in a way that's a one-stop visit. We found over COVID, and we've had a lot of our GPs who've been a bit unwell, or even not just with COVID, with other illnesses, are able to do triage from home. And I think we'll see in the future that a lot of GPs who maybe retire will take up an option of doing virtual work on behalf of practices or for their own practice. Patients and providers, we like it. Might labour the point, but capitation is a fixed sum of money, and having people come in dilutes your capitation. So having more consultations does not make money for practices. Some ways doing efficient triage and dropping utilisation rates is actually good for business. Plus, of course, it's a requirement for a model of care if you want certification or accreditation. And that's what I won't labour this, but when we're doing our work to look at practices, how they're going, we've got on the left-hand side where they're not doing triage right, it's how they're doing it systematically all day with someone who can diagnose and order and prescribe. Sometimes I just show that slide. That's one practice, Tikipunga in Whangarei. That's 1 month of their resolution of triage for patients in their practice. That in itself is pretty telling. There's people driving up to an hour and 15 minutes down middle roads. Often we've got problems in Northland both with quality of cars, quality of roads, lack of petrol. And if you don't have to leave home to get your problems sorted out, there's an incredible advantage to our people. I think too, I've often shown this, that telephone triage might be one little bit there about when people are unwell, but actually fills all aspects of delivering care to unwell people. but also it's got quite a lot of other parts of our model of care that are benefited. So one simple activity within your practice can make a massive difference to how well the practice runs. So I said patients like it, we like it. I think it's done a lot for our well-being in the practice. And this is just a little bit of research. 2 years into the model of care in Northland, we did some qualitative research and interviewed our staff members. Top green, that's patient, the green is triage. Administrative and reception staff absolutely love triage. The problem with otherwise phone calls coming in and of clinical nature and then having to try and organise appointments for people across a busy week was incredibly stressful and actually wasn't working well. So for them just to simply have a script to say, give me your best phone number, our clinical staff that will ring you back, is great for them. And our doctors, managers and nurses all like it. You can see quite down the middle there. It's a well-liked process. And it's simple. So anyone on the webinar who's doing triage, I really recommend that they use the Procon tool that is available to you. Without this, it isn't anywhere near as easy. This tool allows you to simplify the process into a normal clinical process, right back to your notes, and allow all the data analysis needed to make this lean. And so without this, it's nowhere near as efficient. So what we do is just go through this form, write what people have told us, go to an outcome, got the ability to bill people directly from the form, right back to the notes, simple as that. The other bit of this form that's important, oops, sorry, is the, I gave up, doesn't matter. The other bit that put in that form is actually putting down what happened in terms of if there was a GP appointment, whether it's urgent or non-urgent, because you need to know from that how many book on the day appointments you need for each day of the week. Without that analysis, it's hard for the practice manager to make sure this is as efficient as possible. That form requires no training. We like making the calls. We don't have to do any data handling, and it is a very lean process. Just showing you a little bit of data from my practice. This is all the resolution rate for all the people that do calls, nurses, paramedics, and doctors, running about 38%. If I look at doctors, we're running closer to 50% across the all calls, and we do aim with our practice to do as many calls in the morning with doctors, and then our paramedics work for the rest of the day. We do a lot of calls. This is our number of triage calls per month across the last 3 years, and we're probably averaging just over 1,000 calls a month. We also have a very busy day, which you'd imagine is Monday. You can see that Manhattan. Our Mondays are by far the busiest day. We actually have 11,000 patients. So on Monday morning, we have 3 doctors and 2 paramedics calling for the first couple, taking calls for the first couple of hours. This Monday, we had 65 calls in the first 2 hours in the morning. Biggest day was 105, 4th of July last year, and we rolled 3 people into the Tuesday, which we saw as a failure. We try and solve every single person's problem on the day. Other thing I think that's really worth noting, that top graph shows the pro rata rate of phone calls by ethnicity. So for Māori versus non-Māori, more Māori patients are dealt with and making phone calls and being sorted out through this triage process than non-Māori. There is no bias in this. The phone calls come in, the name is, the phone number is put down, problems are resolved. I think that's an important thing, and this is across every practice in Northern, we know this. It's one of the few things in health that actually we can quite rightly say is equitable, truly equitable in terms of delivery. I think too, maybe I should have shown that first slide first. That's just our call handling at my practice. If you're running a triage system, you don't want people waiting on the phone or dropping off the phone. That's fairly staggering. We had, in those 4 months, 15,000 phone calls, 529 of them, which is less than 3%, about 3%, took over 30 seconds to answer. I love being able to ring other places and having the phone call answered quickly. And certainly if you're doing triage and you've got a volume of calls, that's a really important thing to be monitoring inside your practices. We've probably got to do a bit of fine tuning. I think that when that process, the electronic process I showed about using the form, we probably need to standardize when people start and stop the process to know a bit more about length of calls. We are considering using some of our practitioners who are really good at resolving as our champions. Some people don't like the process and probably could be left without doing that, because you don't have to do this if you don't really like it. There isn't a correct resolution rate. I mean, it's clinical judgment, so we're not aiming to increase the rate. But I know that those that don't like to do it tend to try and shorten calls and book people in when they probably might be sorted with a bit more effort. We are forever fine-tuning our supply and demand in terms of that data I showed you. And I think we're actually trying to make sure that patient test is fulfilled. So I'll just run quickly through portals, because it's another thing I think that's really important inside our model of care. We are same way I showed you before, that if you've got a functioning portal, then a whole bunch of things inside your practice improve. But this is slightly older. It's from a couple of years ago. More females than males and through management health were enrolled. You can see on the right that this is used quite well by, or more extensively by, people as they get a bit older. We've got people in their 80s and 90s who are active users of management health. Many are very computer savvy. They're doing a lot of video work with their grandchildren and have no issues. So we make no assumptions around who should or shouldn't be offered it. And so why we use it? Because I think it helps our patients practice with their workload, particularly administrative and nursing staff. They've certainly seen a big improvement in stuff they're not having to handle with telephone calls or post-it notes. Patients like it. I mean, they're able to see all their results and self-manage, and gives them another way of getting hold of us, that other than having to make phone calls or come in. I do look at the other practices within the collaborative, and virtually all of them are offering open notes, which I won't talk about, but I think it's something that we have seen good uptake with, and something that really patients like, and it's got no reason not to. We've never run into a problem with it. We have a lot of people ordering prescriptions. Obviously, it's a simple system. Again, virtually all the collaborative practices are offering secure messaging, meaning that patients can message the practice. That does add a bit of work, I think, to GPs, but it's incredibly useful for patients to be able to get information directly from their practitioner. People are able to receive appointments. They're not making appointments in my practice moment because of COVID. We're just viral screening everybody, and get updates about other things as well. So I was going to mention briefly, I mean, probably not for our collaborative practices, but we've still got a problem in New Zealand with uptake of portals. A lot of practices are quite resistant to even offering it at all. And then those that are offering it are only offering it selectively, which was disturbing enough to the Ministry of Health that they actually got Controller of Auditor General to do a report back in 2017 and came up with this sort of list here. I'm not going to go through it, but all the things that they were heard were barriers to actually using a portal. And if I work my way through them, not one of them is actually valid. Maybe the only one I would suggest is increased workload to GPs, but that can be managed by giving them time to do it. It's a different type of workload. It's not adding work, it's just shifting your work to another part of your day. So many other things that people are worried about either don't occur or actually have got no basis in fact. And that's where it came from, this thing, because they'd seen only 70% of practices at the end of it, what was at a 6 or 7 year period, actually offering portals. And just to put that in perspective, I said, 70% offer it to 20% of people. It's only 1 in 8 people in New Zealand in the last 9 years have been given a portal. Just most of those practices that are offering open notes, healthy homes practices, so only 1 in 50 people have got open notes, which is crazy. And when you think about banking or travel or accommodation, other things that are true, I guess, service industries, we aren't performing very well. Just my last slide, I think that for people that are embarking into using portals or having some issues with them, we've learned a few lessons over the years, and probably the first one is having some rules of engagement with your patients as they sign up to what they should and shouldn't be doing with it. So we have rules that would say there's a 72-hour turnaround for portal messages, not to use for urgent unplanned care. It's not for use as a message to the provider to do repeat prescriptions. We've set aside time for our GPs to deal with their management health inboxes that are getting quite a lot of messages. They have an appointment set aside to do that. If we do get repeat prescriptions or urgent prescriptions or messages for urgent care, we do not fulfill that, because if you do, then they're going to come back at you again. So I will say you can order up your repeat medications via Management Health, or please ring GP Triage if you need a prescription or you have an urgent problem. We're careful about using the out-of-office functionality, so none of our doctors are getting messages or when they're not actually at work. We avoid long threads. We're not consulting. We're just finding that if there's more efficient ways of dealing with things and we have to get people in, we just say, well, we can't do justice with what you're asking through, through a message. Please ring and make an appointment, or we'll organise, to do it another way. Another thing I think is that we're just all busier. I think we've all got more work to do than we ever have. And this feeling this management health work or portal work is a whole new burden. It's not the fact, it's just, it's going to appear one way or the other, either in bits of paper or messages, verbal messages, or emails, or someone tapping you on the shoulder. And I think it's highly efficient, actually. I think that doing it this way is one handling of my things. It's not extra work. It's just, I think we're all really busy. So just finishing, I think if you get those things working, you get Triage working, you get your portals really humming, then you go a long way to actually get your train back on the tracks and feel happier with work, and you'll have happier patients. So that's me. Thank you very much.
Thank you, Andrew Namihi. And there's just such a richness of Andrew's experience, and really he's kind of focusing on those what sometimes we call the low-hanging fruit within the model. Now, there are obviously 38 characteristics in the whole model of care, but as Andrew showed, they're very, very linked, so you start with the building blocks, there's 12 of them, and they link out into all of the others. So I think drawing on everything that Andrew just said, there is some real quick wins in there. Now, Kirsty will share a little further in terms of her own experience, and then also touch on the whole certification process for healthcare home in terms of us maintaining national standards around this model, and then continually improving it, from all of the experience that sits within our network. So over to you, Kirsty, to bring your experience to life.
Thank you, Amarjit, and thank you, Andrew. Yeah, I suppose initially I'd like to just kind of reiterate what Andrew is saying around these two being kind of quite pivotal, I can't speak tonight, in the kind of model with the view to improving access for patients. I would add to his list on the portal of learn to charge for your time early would be another addition to that list of what to do with the portal. But I was speaking to one of my colleagues today, and because she was asking about what we were going to talk about in the webinar tonight, and she said basically she felt that our practice wouldn't actually be surviving if we hadn't have kind of taken on board healthcare home model. And we've been now doing healthcare home for 8 years, and we've incorporated pretty much every part of the model now into our general kind of business as usual. And I don't think she would be working. She's near retirement age, and I think that prior to this, I think it would have been easy for her to walk away, but she's enjoying her job again and kind of staying with it. I think there are a couple of other areas that maybe really do kind of add in, and Andrew did kind of talk about his extended care paramedic, and that's part of that extended team that is part of the healthcare home model as well. And we've kind of extended our team as well, and lots of practices have also incorporated new roles within general practice, so including health improvement practitioners. We have a clinical pharmacist, health coaches, clinical assistants. So for my clinical assistant does actually help me with my portal work, in that she goes through some of the portal messages to weed out the ones that maybe I don't need to deal with, information that's come in from a patient about an admin thing, or information that's come in about a prescription that's not kind of in their normal, or they haven't mentioned where they'd want that prescription sent to with a which pharmacy. She is doing a little bit of work around that, helping us manage that, as well as our inbox management. So, there are roles here that can kind of help, and that extended role that we're developing within practice is kind of a huge advantage. So it's making sure that we are doing the work that we are best at, and that everyone is doing the role that they are, trained to do, and we're not doing things that are, somebody else could be doing for us, which again helps that workload that kind of fits with it. There is obviously the kind of continuous quality improvement part of the model as well, which involves some lean processes. Again, Andrew kind of referred to that. And I think that's become business as usual. It's an efficiency. It's efficiency in the workplace, efficiency in the environment, and efficiency in any of your processing. And every time you develop something new, or you think about something new, or you're developing a new service, then you rely on those building blocks that are part of the model to kind of take you there. And I think those are kind of crucial. And at every step, equity is part of that. And I think the other thing is that all of this model does kind of fit with some of the new cornerstone kind of the continuous quality improvement part of Cornerstone, or the equity module of Cornerstone. So a lot of it does cross over, and we should be kind of not duplicating work. So it should be across both of those as well. So we use things like process mapping. Visual boards are hugely important. That daily huddle with your visual board at the beginning of the day just sets your day up. Who's there, what are we focusing on, where are we not falling down. We've used our clinical assistant to improve our cardiovascular disease testing for our practice. She's had a real equity focused on that, and kind of been phoning our patients to come in. So taking a workload away from GPs, really. So I think that is another part of this model, which is absolutely at the heart of it, a change model. And I think that's what is kind of key to Healthcare Home, is the fact that it does allow you to change, and it allows you to adapt. So we unfortunately have lost some of our younger GPs who just can't face the stress. And I think the trauma of COVID also affected them quite badly. And so at times we've had to increase our triage time to fit with trying to manage our daily demand in a much better way. But you adapt, and you use the kind of those building blocks to kind of make those adaptations, and it makes all the difference. So the other thing that I need to talk about is the certification process, which I think Amarjit's going to share a slide on that. So I think this isn't just about mine and Andrew's practice. This is about the practices we're seeing across the country. So as part of our certification process, we are getting practice can kind of tell us what they're doing, and we're getting information from them. And it's amazing, actually, the initiatives, the equity that has completely changed general practice. I mean, it's not general practice it was 8 years ago. It's absolutely changed. And the voice of equity is now kind of key to everyone. And I think we are seeing that in the whole certification process. So the process is shouldn't be too onerous. There is a little bit of work attached to it in producing some paperwork for us so that we can see what you guys are doing in practice. And that is really important. And the more information you give us, the better. So we do ask for a little bit of evidence about some of the aspects of the model. So we do look at some of our triage numbers, but we look hugely at where is the equity focus in this. So that paperwork comes in, it's then sent out to moderation, and 2 different moderators look at that paperwork, make sure that you're fitting with the certification process, that we've got the information that we need. They comment on the good things that are happening in practice, the ones where maybe they've got some concerns. And then once every 3 months, we get together and we have a virtual meeting. And the PHO or a member of the practice comes and presents the practice to us. And that just gives us the ability to go over those queries that the moderators have raised, make sure that we've got all the information we need, and then we can proceed to certification, basically. But it's quite a good conversation, and we tend to like to give feedback to practices about what's going well, where they're really thriving in the model, maybe where they need to think about where to go next, and which parts that they maybe need to work on. So, I mean, it is a process, and we know that over the years, you know, that you progress through that. So not everything has to happen at the first attempt. But certainly, you know, we like to see, we've seen that with years, that basically the practices are developing, they change their area of focus, they come up with new and innovative ideas. They're really very positive, and it's wonderful to see the changes that are happening, you know, throughout this model. So yes, I think it is an amazing model. I think it's great to see practices taking it on and to develop. I think there are bits of the model that some practices will like and some practices won't like. And I think that's fine. Take what you need from the model, use what it will work for your practice. That's actually what is at the core here, is you have to do what works for your practice. But as Andrew says, you know, it puts your trains back on the tracks. And that's really what the important part of this is.
Yeah, all right, Kirsty, that is awesome. I see there's a question there in the chat. What I might do is hold that until we Whaea shares her wisdom around lived experience and around, you know, what's important for those, you know, accessing the services. I just wanted to share this slide, Whaea, as a reminder of your involvement back in, gosh, prior to 2020, because it was a long journey leading to launching the enhanced model of care. And this was just a reminder of that for Caro and your involvement in this with us, and just and taking us on this journey, just how much richer this model is. And so your fingerprints are all over it, so we appreciate it. And as Kirsty and Andrew referred to, this is a deep model, but a very connected model with lots of content and lots of support behind every one of these characteristics, and that is open sourced on our website. This impact statement just shows the impact in terms of the MAHI and to the collaborative, but more really why I share it is to share that this tile here, 381 practices across Aotearoa on this journey, and 2.37 million benefiting from this model enrolled population. Now, obviously, there's work being done around the unenrolled. We've still got more MAHI to do, but it is impacting this sort of health and well-being of our whānau. So it's moving along. There's a lot more we can do, but I think if we hear from Whaea Merle, then we might get some more tips on just how better to support our communities to access this model. So over to you, Whaea, and then we'll open up for some questions before we sign off for the evening.
Tēnā koe Amarjit. Kia korua, Andrew and Kirsty, for your points. Absolutely wonderful. Now, just to share about my journey, 3.5 years ago, when I came on board, I really wasn't sure what my whole role was all about, that I was the consumer, maybe in the Māori space. I never heard before about being the voice of lived experience. And so in the 3.5 years that I've actually been with Healthcare Homes, much has changed. I didn't know the language very well then, to know that, well, first of all, I thought Merle was there and Merle had a job, I did. But did I realize that I was there to bring forth all the voices of lived experience and to help impart and allow many others that never hear them? Yes, you might know of it, but to actually hear, I waited for 2 hours in the surgery or in the waiting room. Somebody else might say, oh, I waited for 6. And, you know, you think it's a conversation and you let it go. However, first of all, before I jump into that about what those voices brought me, for me to have this space right now, a heap of gratitude and thanks to Collaborative Aotearoa that they would provide this space for the voice of lived experience to actually have their say. And it wasn't only having our say, it was about whatever the modalities of communication have been. Collaborative Aotearoa have supported every which way for us to look at the model of care and enhancing that model from the start. As a newbie on the block, I couldn't see, just as my journey seemed like a mystery bus tour. I believe I got on the bus and I had no idea where I was going. I kept looking around and thinking, well, I don't really know anybody here. And for fear of maybe not looking good, I couldn't really ask, what's my role? What should I do? And even when I got given material or spoken to, it was still all quite overwhelming to start with, until I realized that my role and a gratitude for it, because in every space that I have an opportunity or have had the opportunity to be in, I am able to share what those concerns have been for the patients that go to clinic, patients that where they have had ease of access, you know, patients and their waiting time, things like that. I didn't know that there would come the day, and it came sooner than I thought, that those kinds of concerns were actually part of our model of care that we were enhancing. So with Collaborative Aotearoa, at that time, house care homes, what was wonderful was, as I mentioned, my journey felt like a mystery bus tour. At one stage, Dr. Dougal was there. I'm sorry, Dr. Dougal, I don't remember your surname, Thornton or...
Yeah, Dougal Thornton, yeah.
Wonderful man who shed so much light on the conversations that had happened. So every time I met at that time with house care homes, it felt like a bus stop, just the way the mystery bus stopped. I didn't know half the people that got on the bus and many that were getting off the bus. Did I know that they had shared all their nuggets? And it became a listening and a watching type journey for me, because the more I listened and realized that unless they are talking the language that resonated with me, I could not have claimed to have been a good listener, whereby bringing back the voices of many of our whānau of kuia kaumātua mokopuna, when things weren't happy, that was when I realized my role in there was about elevating those voices, elevating whānau voices, so that I feel like I'm not sure if I should have come backwards into this, because Andrew and Kirsty explain what they spoke about, and it was very clear. So I'm sorry if I am jumping for anyone. When I went to Hui with the rest of the team, even with the governance team, the wonderful thing about being there was feeling like we were being heard, listened to. And I never felt that I was just being heard. I felt that we were being heard. Everyone that laid that concern, they moaned about waiting time. Their concerns got higher when they spoke about not being able to actually talk to the doctor properly, not feeling heard, not having a say in how their health care went. And with those shares from the whānau, I was able to bring them back to the table. Why I know now that I was sitting at the right table with the right people at the right time was because when the enhanced model of care was brought forth, the elevated whānau voices that I had shared on behalf of the many that were unable to be present were put. I am just going to hold this piece of paper up. Enhancing the healthcare home model of care. I had a big part, as did all our team, in sharing how that came about. And it all came from the hui, where we sat with many others and we shared what worked and what didn't work. What were whānau saying? How were they feeling? How did it affect them? Did they think that the treatment they were getting, did they feel like there was a relationship with their GP? Did they want a partnership? And you know, as a self-management facilitator, self-management educator, facilitator, in that role for myself, that was a really important part, was hearing how people felt. Here in this space, on this journey, healthcare homes, collaborative Aotearoa, you have made a huge difference to the many whānau that are out there. When the model of care to enhance that model came forth, we spoke a lot about whanaungatanga. What did it mean? And what was that 19-letter word going to do for people who didn't know what it was or what it meant? Whakawhanaungatanga. It's about finding those things within oneself that bring forth kindness, that soften the heart. This is human kindness, one to the other. It was about freely giving in the space of well-being. We were looking at people treating people like people, and that you were special. You were special today. You are with the doctor, and you have an opportunity to share your concern. Many of my whānau and the way that I came into the space, and even when I have gone to my appointments, I have found that I have felt heard. I've been uplifted while I was in there. You know, maybe you do or maybe you don't. Tātou te iwi Māori are an experiential people. We like the thought of an experience, but a good one would always make us remember it. You know, I might not remember everything that you say or tell me, but I would certainly remember how you made me feel. And for that experience, I would return. As I have heard feedback from many of my own whānau, of which I keep in touch with all the time. If I know they're going to hospital or the doctors, I will ask them different things about, so what happens when you get to the doctor? And as soon as she told me, I thought, oh my gosh, you have to be a house care homes practice. And because the whanaunga said to me, well, it's awesome actually. I think I'm with a kaupapa Māori clinic. I'm new there. I said, okay, so how does that go for you when you go there? And she said, I just love the way they greet me. She said, even from the door, I get a big kia ora. And she said, I can't wait to take my shoes off and get inside. But I know for myself, with that kind of experience, I would go back again. I feel like I'm looking at someone that looks like me, and maybe they will even know what I feel or I think. So what I want to tell you about healthcare homes and the things that I've learned and the journey that I've been on. Healthcare homes have provided myself as one of the voices of lived experience, the kind of nurturing that would make this flower keep growing tall. I believe that the surgeries treat every one of their patients that come through the door. If you are not greeted and welcomed, you are taken into triage, and then there's a meeting of warmth. Is it a warm handover? Was it the smile you gave or they gave you? Whakawhanaungatanga is to be actioned. That's what that word is. Whaka is to cause, to make happen. Whanaungatanga is about the relationship between people. If we can do it in the space of well-being and health, coming from the place of human kindness, I would hope that many more people would come to realise that with healthcare homes, collaborative Aotearoa, what we set out to do was to help the many people who have come into practices using this model. Was about getting in touch easier, all those modes, having effective appointments, being aware that they could do the blood test or the urine test before they came into the clinic, and that their results would be there, as would be the appointment with the doctor. Also, improving the practice atmosphere. That was absolutely wonderful. That just does so much for me when I hear kia ora. And we actually set out to offer the people, the patients, a lot more than what you were initially getting. Now, you won't know if you're not there. And as I said before, I believed I was in the right place at the right time and I got the right care. And I believe you can get that from healthcare homes, collaborative Aotearoa now, who are working with you, for you, and also you have an opportunity to talk about your care, doing it your way. Yes, I am collaborative Aotearoa struck.
Awesome.
I believe in the model of care, and I have faith that this works. My own care is with healthcare homes. I'm grateful for the opportunity from our team and healthcare homes or collaborative Aotearoa. Amarjit, thank you very much. I'm sorry to take the time right to 7:30.
We, you know, we just love your korero and the richness that you share with us. And, you know, so I'm pretty sure others would have received lots of gold nuggets in there. So we're just very grateful to you to keep us grounded in reality, you know. So, and it is about those whānau voices. So ngā mihi nui, Whaea Merle. Yeah, we appreciate you. So I'm conscious of our time as well, just generally, but the richness has been worth it. I know we've asked for questions to come through the chat. We've had some reflections and that's been really cool. We'll capture those, but if you do want to follow up with any other observations, questions, we're happy to follow, you know, to actually respond to you via email. I'm going to share with you just the contacts in terms of the team, and then I will ask to, we'll go into closing karakia unless there are any burning questions from anyone. I've highlighted Patria's details because Patria is our change lead for Healthcare Home. You can certainly reach out to any of us, but Patria is really, you know, moving ahead in this space, hitting the ground running for us. So feel free to reach out directly there too. Would anyone like, Merle, would you like to close us, Whaea?
Ai, ka pai tēnā.
Ka pai.
Kia ora mai tata katoa, tēnā koutou mo te kōrero a te pōnei. Anei, he karakia whakamutunga mō mātou. Kia hora te marino, kia whakapapa pounamu te moana. Kia tere te karohi rohi I mua I te huarahi. May peace be widespread. May the sea glisten like greenstone. And may the shimmer of light dance across your path and guide you on your way. Ake tonu ake, āmene to you all. Kia ora, Amarjit.
Kia ora,
Āmene.
and Homari, and have a wonderful evening, everybody. Thank you for joining us.
Thanks.
Thank you,
Yeah.
Hei kona.
Bye.